Hello, my name is Jessica Basant, and I am the Program Manager for the tele-ophthalmology program called Tele-Eye Care at the University of Rochester Medical Center Flom Eye Institute. Today, I will be presenting on vision care, specifically evaluating the impact of primary care-based tele-ophthalmology programs on diabetic retinopathy screening rates and follow-up care. Diabetic retinopathy is the leading cause of blindness, predominantly affecting low-income, minority populations in the United States. Despite developments in telemedicine, primary care clinics face challenges in maintaining teleophthalmology programs. We examined the impact of teleophthalmology in evaluating diabetic retinopathy and visual acuity in 3 primary care clinics in upstate New York. Patients with diabetes have a 95% chance of preserving their vision, as diabetic retinopathy is a treatable condition if identified early. However, the rate of annual diabetic eye exam in certain safety net primary care clinics for low-income population was 41% at the University of Rochester in 2018. To address this care gap, the University of Rochester and Excellus Health Plan partnered to support a tele-ophthalmology program called Tele-Eye Care at the Flom Eye Institute. Tele-Eye Care is a coordinated effort between primary care, ophthalmology, local insurances, and health information technology and administrative support to assess ocular health in non-ophthalmic settings. This combined effort aims to increase access to timely eye care, thereby increasing rate of diabetic retinopathy exams to reach the 90th percentile. Through the Tele-Eye Care program, staff at primary care clinics incorporate distance vision assessments and uses non-mydriatic fundus camera to image the eye of patients with diabetes. Specifically, primary care staff identified patients with diabetes who did not have a documented dilated eye exam in the last year or do not remember when the last they had an eye exam. To assess this population, we used the store and forward process. Retinal images for the left and right eye were captured using a Topcon NW400 non-mydriatic camera during a patient's primary care visit. The images are then securely uploaded to the Flom Eye Institute Reading Center for reading and reporting by an FEI ophthalmologist. Once the reports are generated, they are sent to the clinics and are incorporated into the patient's medical record. Patients are then contacted by ophthalmology staff to follow up with an eye care provider according to their vision and imaging assessment. Data coordinators at each primary care site ran a gap list report to identify those who have not had an eye exam within the last year. 1,718 patients were identified for the Tele-Eye Care program, but only 558 patients were examined through our program. We were unable to assess 160 patients due to reasons such as not showing up to their PCP appointment, they were not interested in the eye evaluation, they did not have enough time to participate in the evaluation, or some form of technical error may have occurred during the screening. Our patient population consisted of 56% females and 44% male, with a mean age of 55 years old. Furthermore, our program assessed a diverse group. The grade of our population was found to be among African Americans at 53%, followed by white, Hispanic, and Asian Pacific Islanders at 28%, 17%, and 2% respectively. The Tele-Eye Care program assessed 78% of patients with diabetes needing an eye exam. Of the 78%, 27% could not be reached with results, 3% declined a follow-up appointment, and 12% of patients agreed to follow up with their own eye care provider. 59% were successfully contacted with results and agreed to make a follow-up appointment at the Flom Eye Institute. 29% of this population showed up to their follow-up appointment, 15% were scheduled for future appointments, and 13% no-showed. Our program appropriately triaged patients to see an eye care provider for follow-up eye care. Referral at 1 or 3 months' time were for those with significant issues such as vision-threatening retinopathy, 1 month or less, and other significant eye conditions such as poor vision during an in-office testing for 3 months. We closely examined those who were asked to follow up within 1 and 3 months and found that 292 patients were recommended to follow up within this time frame. 48 patients had vision-threatening retinopathy and were recommended to follow up within 1 month, and 244 patients had other significant eye conditions and were recommended to follow up within 3 months. Let's take a closer look at the 1-month recommended follow-up time. Of the 48 patients, 77% made and kept an appointment within 1 month. 50% made and kept their appointment within 2 to 3 months, and 33% did so at 3 months or more. Of the 48 individuals, 42% made and kept their appointment within 1 month or sooner. Of those who completed their follow-up, 83% did so within the recommended time frame. In total, 38% of the 292 population followed up as recommended or sooner. Due to these successes, 53% of patients met the 90th percentile HEDIS metric goal within the year. Of the 558 patients, 78% were found to have no retinopathy, and 15% were found to have retinopathy. Of those with diabetic retinopathy, 3% had apparent signs of diabetic macular edema. Additionally, 19% of those with diabetic retinopathy had other pathology detected, such as glaucoma suspect, cataract, and drusen. Furthermore, we obtained a binocular vision of our patient population. 70% were found to have good vision, which was greater or equal to 20/20 to 20/40. 9% were found to have less than 20/40 to greater than 20/70 vision, and 6% had vision of 20/70 or less. Our findings indicate that performing eye evaluation using a store and forward method helps to timely triage patients to appropriate care, and thus this approach serves as a viable solution to addressing the gap in diabetic retinopathy care. However, despite increase in DRE rates seen in our program evaluation, many barriers exist in sustaining the continuity of eye care. We have the opportunity to increase awareness of effects of diabetes on the eye, improve patient and provider communication, and unite our electronic health record with the tele-ophthalmology solution to optimize workflow in primary care. This, in turn, will improve DRE screening rates and follow-up care. Our next steps to improving the program includes working with social workers and care managers at primary care sites to contact patients who no-showed or could not be reached with results. In doing so, we will understand the barriers they face in getting such care, and thus provide the appropriate support. Additionally, we find that many of our safety net clinics are often short-staffed. To mitigate this, we believe involving non-clinical staff, such as data coordinators, to do the screenings and lead the program at their sites would be highly advantageous. Lastly, we find that there is a need to improve outreach and education about eye health within the community. Performing screenings at local churches and community health centers and build partnership with local organizations will not only allow us to increase awareness of eye health and diabetes, but also increase access to care, increase individuals' willingness to seek eye care, and ultimately improve health outcomes. We would like to thank our partners at Culver Medical Group, Manhattan Square Family Medicine, Strong Internal Medicine, Excellus Health Plan, and Accountable Health Partners. For more information, please visit our website at the link below. Thank you.